Now, this is the opposite of what's called pseudoscience. And pseudoscience is really a problem nowadays. It's always been a problem, but now with the internet, it's a real problem. And it affects everything. It affects the way we practice medicine. It affects people's personal beliefs on things. It affects bad outcomes that people have all the time. And the reason why pseudoscience is different than actual science is because pseudoscience starts off with the conclusion already. So someone who practices pseudoscience will say, hey, these crystals, I know they're good for my inner gut, microbiome and well-being and whatever. And that's the conclusion. They start with the conclusion, and then they start to figure out why that's the case. If they want to go any further and not just go based on just whatever their beliefs are, then they try to look for data. So it starts with a conclusion. It's based on beliefs and feelings, anecdotes, what you heard from somebody, what you saw on the internet, ancient wisdom, the fallacy of natural stuff being better than anything else, etc. And there's a million different things that fall into the pseudoscience category. Welcome to the Real GI Doc Show. I'm your host, Dr. Fred Gandolfo, and I'm a board-certified gastroenterologist with a medical practice in New York. On today's episode, we're going to cover a lot of stuff. We're going to be talking about proton pump inhibitors, also known as PPIs. We're going to talk about how they work. We're going to talk about some risks of PPIs, and we're going to talk about scientific research in general, because this is a complicated topic, and it all spawned from the fact that lots of people are prescribed PPIs. They're very commonly prescribed drugs, and you've probably taken one yourself at some point. These are drugs like Nexium and Protonix and Omeprazole or Prilosec, and there's many other ones, and some of them are sold over the counter. Now, these drugs are great. They work amazingly, and they've changed the treatment of many common GI diseases that used to cause all kinds of problems, major problems. And the problem with these drugs is that they have all kinds of information out there that they may cause pretty ugly side effects, and the research is all over the place. So I get this question all the time from patients, and it's sometimes problematic because, like, the drug they need is a PPI, and I give them the PPI, and they come back in a week and say, I went on the internet and I realized that these drugs have a million different side effects. I don't want them. You need to give me something different. And we'll talk about that, but there's lots of stuff out in the internet. I wanted to kind of debunk some of the myths and talk about how research is done and some of the limitations of research and some of the strengths of research. And I wanted to talk about, specifically to this topic, I want to talk about PPI and dementia risk. So this is the big one that's out now. PPIs have been villainized or looked at in a negative way for many years now. And dementia is now the more recent thing that is coming up in the news, but they've been looked at for causing strokes, heart disease, cancer, kidney problems was the first one, I think. But there's a whole bunch of things that have been looked at and kind of like debunked or maybe taken more into context and not blown up into something that's a crisis when it's really not. So let's start off by talking just about what PPIs are. So a PPI, or a proton pump inhibitor, basically is a medicine that you take. They come in intravenous forms, but mainly people take them in pill form. You can get them over the counter. You can get them by prescription. And they work by stopping stomach acid production. So you take a drug like a PPI when you have problems with stomach acid. And what they do is they basically block the little pumps that are located in the stomach parietal cells. And we've covered this a long time ago, how stomach acid is made. So if you really want to dork out about it, you can go back to one of those episodes about stomach acid. I'll put a link somewhere in the bottom of these show notes for that goodness. But basically, your parietal cells make stomach acid in response to a meal and other factors, and they have little pumps, and these little acid pumps can be blocked by these drugs called PPIs. The name of the pump is the hydrogen potassium ATPase, if you want to go back to basic science stuff. And what happens is your stomach acid, you basically make acid when you digest food. The pH, or the amount of acid, is very, very low. It's close to battery acid. It's not filling your stomach to the brim, but it's on the surface of the stomach lining and it helps to digest the food and break down proteins and activate enzymes, etc. Now, your stomach acid also can cause problems like heartburn and stomach ulcers and other things like that. So if your acid is allowed to just persist and you have an ulcer, it's just going to keep burning a hole in your stomach. And the magic happens when the acid level falls. So when you're able to, with the magic of healing, the body will heal an ulcer or heal inflammation caused by acid if the body is allowed to get that acid level down. And basically when the pH goes up, the acid level goes down. So if you take a PPI medicine, it brings your pH of your stomach acid, it makes it less acidic. It brings the pH up. So if you get the pH above 4, which is still acidic, but not, water is 7, that's neutral. It's still acidic, but it allows healing to happen. And your body will go in there and heal an ulcer and heal up some acid reflux damage if the pH is allowed to stay over 4. So that's what PPIs do. You take them, they last most of the day, but most of the effect is done in about 20 hours or so, or maybe a little less. But they're billed as 24-hour drugs, and basically the first one that came out was omeprazole. This is Prilosec. This came out in 1989 in the United States. 89 or 90 was on the shelves. So it was prescription only, and then it went over the counter. I don't know, a decade ago or so. But this has been maybe more than that. But this has been the gold standard in terms of acid suppression for that long. For what are we going on? 89. We're going on like almost 40 years. At the end of this decade, it will be 40 years of having PPIs around. So why do people take them? Well, you take them when you have issues like GERD or heartburn or reflux disease. You take them for stomach or duodenal ulcers if you have peptic ulcers. You take them if you have a problem called dyspepsia. Dyspepsia is when you have discomfort after eating, and it's not from an ulcer, and it's not from a cancer, and it's not from a gallstone, and it sometimes is related to stomach acid. So you try a PPI, and maybe it works in some people for dyspepsia. And it's also used for other miscellaneous things, including prevention of stomach ulcers, for older people who have to take aspirin or NSAIDs, or people who have had ulcers in the past and have to take like Aleve or Advil for some other reason. Sometimes we give PPIs to prevent an ulcer, and there's other miscellaneous reasons why people take them, but mainly it's for GERD, which is acid reflux, and ulcer disease. And you could take them different ways. You could take them chronically, like if you have a condition that's related to reflux called Barrett's esophagus, which is a precancerous condition in the esophagus. You could take PPIs chronically to prevent getting esophageal cancer. You could take a low dose every single day. If you have chronic heartburn, never goes away, you can take a low dose of a PPI every day, and usually you're okay. They're also given intermittently, meaning you take them for a week or two at a time, or a month or so at a time, and then you kind of taper them off and stop them when you're out of the woods and feeling better. And then maybe 6 months later, you have a flare-up of your acid condition, and you take them for another 2 weeks, and you go on and off. And that's a good way to take them. And some people even take them as needed, meaning, hey, I'm going out tonight and I'm eating some calamari with some red sauce and some pasta and maybe a steak, and then I'm going to have a couple glasses of red wine and some dessert, and I know I'm going to have heartburn all night, so I'm going to pop a Nexium or a Prilosec or whatever that evening, before dinner, and it's going to help me overnight. That's not the best way to take them, but people do it like that, and it works, truthfully, if you just have intermittent symptoms. And that's, a trade-off. You're doing something to your body bad with the food and everything, and you're taking a medicine to kind of prevent those natural effects, and that's kind of like what you're doing. It's not really treating a disease, it's really just helping with symptoms, so you can go out and kind of eat whatever you feel like. Now, what do we do back in the day before PPI medication existed? Well, we basically had another medicine. We had medicines called H2 receptor blockers. These are histamine blockers. And you may know a medicine called Pepcid. It's still over the counter. It still works to reduce acid. It does not bring it down as much as, or it does not, reduce the acid as much as PPIs do. But it's still somewhat effective, especially for symptoms of heartburn. But Pepcid and other H2 blocking medicines don't really have enough oomph to really heal an ulcer or to prevent getting cancer if you have Barrett's esophagus. So what do? We had those kind of medicines. We had a bland diet. We can put someone on, crackers and toast and water or milk or whatever to heal their ulcer, which doesn't really work great. And then we had surgery. We could do surgery. We can take out part of the stomach. People would have bleeding ulcers and would die from them back in the day before PPIs came out. And now that basically doesn't happen unless you're not diagnosed or don't go to see the doctor and just suffer in agony at home and see what happens. Or they would have a surgery called a vagotomy, where they cut the vagus nerve that goes to your stomach to stop the acid secretion. That's kind of brutal as well, to cut a nerve to stop acid production, where you could just take a pill now. But that's what we had back in the day. And people would have stomach surgery for bleeding ulcers, and people would have esophageal cancer from chronic acid reflux, and all this stuff just kind of was the way it was until omeprazole and other PPIs came out. And now if you find a general surgeon that knows how to do stomach surgery, it's not a common thing anymore because it's so rarely done, where it used to be a very common thing. We don't even really see patients anymore who had, you do, but they're much older, who had stomach surgery for a bleeding ulcer, because that was done, back in the 70s and 80s, before PPIs came out. And ever since 1990 or so, it just doesn't seem to happen anymore because the PPIs just work so well. So they are pretty awesome, actually, for those things. And, the other thing is, what do you do naturally to decrease acid and to treat GERD and other stomach acid issues like ulcers, besides the bland diet and the histamine blockers and having half your stomach removed or the nerves clipped to your stomach? Well, it's good old-fashioned diet and lifestyle. And we've talked about this before on a prior episode, and I talk about this with patients all the time, but really it's a low-fat diet. It's low amounts of processed carbs. You don't want to eat, 2 bagels a day and have a couple coffees and think that your acid levels are going to be great, because they're not. Watching out for fatty foods, fried foods, large portions, lots of chocolate, coffee, alcohol, citrus, all these triggers for people for stomach acid. So you got to watch out for all that stuff. And the other thing is the weight. You have to watch the weight. So obesity, or even just being a little bit overweight, is correlated with acid reflux. And there's various mechanisms for that, but basically keeping the weight down is the goal. Exercising, not just for weight loss, but just in general, is good to help with reflux for whatever reason. Not eating late at night, so you shouldn't eat within 3 hours of going to bed if you're prone to acid reflux issues. And minimizing stress and getting lots of sleep and all those healthy things that no one has time to do. Those are all helpful as well to reduce the amount of stomach acid that you make. And how else could we fix problems without PPIs? Well, if you're prone to reflux and you have a big hiatal hernia, which is when part of the stomach kind of comes up into the chest and causes problems with acid, you can get that fixed. That's surgery, and sometimes that does the trick. You can avoid certain medicines that cause acid reflux. Lots of people are coming in on Adderall and other stimulant drugs for ADHD, and they have all kinds of stomach acid issues there because they're basically taking methamphetamine, and that stimulates everything to happen. And you can avoid NSAID drugs like aspirin, Motrin, Advil, Aleve, ibuprofen, which are great ways to get ulcers if you take a lot of them. So if you do all those things and live like a Puritan and don't have H. pylori bacteria, which is another common cause of ulcers, then maybe you don't need a PPI drug. But for lots of people who can't keep the weight in check and can't control the diet 100% because they want to live on planet Earth and enjoy some things, then they get heartburn issues, and they often need something that helps, and that's where the PPIs come in. So these drugs they're sorely needed, and before we had them, we did not have a lot of good tools in our toolbox to treat acid-related issues like reflux and ulcer disease, and they revolutionized the treatment of these conditions, and they avoided surgery and avoided death from bleeding ulcers and all kinds of other conditions. But the problem is that people don't want to take them because they go on the internet and they read all these scary things. And of course, if the scary things are true, then they're right. But if the scary things are not true, or if they're only maybe half true, then this is where it kind of gets sticky. And the reason I'm doing this podcast in general, or this episode, especially, is because I don't have time in the office to talk to each individual patient in this level of detail about PPIs. It's absurdity. I'd be 2 hours in the room with each patient, and I try to get this 2-minute, 90-second blurb in about PPIs with people because they ask. So it's a 5-time-a-day conversation. At the end of the day, it's just too much. What I really should do is kind of just print it out and hand it to people on a handout, but that ends up in the trash too. So I'm kind of doing this just to kind of get it all out there. And I wanted to go through all these different issues with PPIs, but this comes up constantly. People are afraid of taking drugs for long-term side effects, etc. And it's a reasonable thing. I would be afraid to take a drug too if it had potential long-term side effects like dementia. But it's important to really understand the nuance. So let's talk about dementia a little bit first. I'm no neurologist for by any means, but what it is it's a progressive loss of cognitive function. So you have memory issues, issues thinking and reasoning, and it leads to functional impairment. You can't work anymore. You can't remember your grocery list anymore. You can't drive a car. All kinds of things happen when you become demented, when you get dementia. And there's a whole bunch of different subtypes of dementia, and they have different mechanisms by which they happen. So dementia is not just one homogeneous thing. It's a whole bunch of different things that lead to the same endpoint. So There's Alzheimer's dementia, which is the more common type of dementia. It happens from certain proteins building up in the brain and other issues that just kind of cause degradation of brain tissue, and neurons themselves don't function anymore properly. There's vascular dementia, which people don't talk about as much, but is super common. It's when you have progressive deterioration of the blood flow to the brain, or less oxygen is getting to the brain because of cardiovascular issues, hardening of the arteries, high cholesterol, strokes, smoking, all kinds of stuff that reduces blood flow to the brain over time and causes microvascular disease, or which is the little blood vessels that feed the neurons, or even macrovascular disease, which is when you have the big blood vessels that go to the brain that are not working because you had a stroke or something like that. There's Lewy body dementia, there's frontotemporal dementia, there's certain diseases like HIV that can cause dementia in and of themselves. There is alcohol abuse, which is a big one. It causes the brain to shrink and it causes damage to neurons. There is repetitive head trauma. So if you're a boxer or something like that, or getting multiple concussions during football, whatever it is, you can get dementia just from the physical damage to the neurons. There's malnutrition, there's Parkinson's disease, and there's some other miscellaneous causes. So there's a whole bunch of things that are causes of this end point of dementia where you can't think and function properly. So why PPIs here? Like, what's the link? There's been a couple of mechanisms that people think PPIs might cause dementia. There's a potential decrease in acetylcholine, which is a neurotransmitter, and that is PPIs have been shown to cause a decrease in acetylcholine for various reasons. So people have said maybe that affects neurologic function. There's a potential but small risk of B12 deficiency with PPI use, and that potentially is linked to dementia as well. And in mice, there are studies that show that there's an increased levels of this thing called beta amyloid, which is one of these abnormal proteins that can kind of tangle up in the brain and cause issues like dementia. So there's a couple of like theoretical concerns where they might cause dementia. It's not totally out of left field. And, so let's study it. Like, how do we study it? We have to have some studies to see if this theory stuff is true. So if you do your research, which I love when people say, if you do your research, I did my own research, and you go online and you type in something like heartburn drugs and dementia into Google, you'll find a couple of headlines, and these are all like news headlines. Top pharmacist warns millions of Brits are hooked on common reflux drug linked to dementia. Another one, dementia, proton pump inhibitor use linked to higher risk. Another one, long-term use of acid reflux drugs may increase your risk of dementia. Another one, a buzzy new study on heartburn meds and dementia doesn't actually clarify anything. Well, that's true. We'll get into that. Another one, could medicines for heartburn be causing dementia? What about this one? Long-term use of certain reflux medicines is associated with a higher risk of dementia, study suggests. USA Today says popular heartburn medicine may increase dementia by 33%. What to know to stay safe? And it goes on and on and on. It's a lot of stuff. Here's one from AARP. Is it risky to take heartburn medication? It might be. So there's a whole bunch of these headlines, and people go into Google and they see like a billion headlines like this, and your brain just takes the shortcut and says, well, if every headline says this, is probably some truth to it, right? So that's kind of where doing your own research comes in. But obviously doing your own research would mean actually performing a study. So when people say that, it's really a logical fallacy. But we'll get to that later. So let's look at some studies. But before we do that, and I don't want to make this a 3-hour long podcast episode, I'd like to talk a little bit about the scientific method, because it's really hard to look at a study unless you know how studies are done and you know what a good study looks like and a bad study looks like. And I'm no researcher, I'm no statistician, and we take, in terms of medical school and residency, we read lots of studies and we get a lot of the stuff drilled into our head about studies, and we look at methods and we learn about them, and we know a lot more about studies than the average layperson does, but I don't know more about how to do a good study than maybe the editor of some journal or an actual researcher in a lab. So take what I'm saying here, with some, relevance that I know something about this, but I'm by no means like the world's expert scientific researcher. But we do have to learn how to read a good study in medical school and residency. So here it goes. You have to start really with the scientific method. So it's a pretty basic thing. You start with an idea. So you get an idea like, hey, maybe PPIs cause dementia, and you create a hypothesis. saying PPIs might cause dementia in people who are taking them for more than 5 years. And, the mechanism is it might cause problems with B12, whatever it is, whatever your hypothesis is. And then you have to figure out how to study this. So how do you actually break this down into a way that we can study this in the real world and draw some type of conclusion? Because otherwise it's just a crazy idea. And I have a lot of crazy ideas, and so do you. And it doesn't mean that they're good or truthful. It just means that they exist in your brain. So how do you actually get this into the real world and test it? You have to figure it out in terms of how to make a variable. So how do we make this PPI into a variable and study it with respect to whatever we're trying to study? So in this case, we're trying to study dementia, and we need to change something in some people and not change it in the other people and see what happens. And then we can say, like, this changing this one thing caused this thing to happen. So therefore, there's some good evidence for you. So here's an example of a really simple study that I thought of when I was kind of making some notes for this podcast, and it might not really hold up to great scrutiny, but it's really just to illustrate a point. So let's study movie ticket sales and the weather. And my hypothesis is that movie ticket sales increase on rainy days in the summer. So if it's the summertime, people are going to go see movies, and I think that the sales are going to go up when it rains. So let's do a study on that. We're going to enroll 1,000 people in each arm of my study. I'm going to take them out of my neighborhood, and we're going to sign them up, and we're going to match them up by age, sex, the movies they like, the movies they don't like, socioeconomic status. And, because if they can't afford to go see movies because tickets are $20, then it's not going to be helpful for the study. So we want to match people up and based on those things. We want to take a bunch of people that are matched for, because people watch different movies, right? Like, you're not going to have a 15-year-old watch the same movie as a 15-year-old boy watch the same movie as like a 65-year-old woman. It's probably not going to be the same exact audience for these movies. So you're going to match them up by all these things, and you're going to follow these people all summer, and you're going to figure out when they buy movie tickets. You're going to have them buy all their movie tickets through some app, and you're going to see like when they buy the movie tickets. So you're going to follow them all summer, and they know they're being followed, but that's okay. So here are the results. We followed these people all summer, and we found that for the 24 hours before a rainy weekend and during the weekend itself, if it rains, ticket sales increased dramatically, right? So lots of people bought tickets on rainy weekends. So I'm going to conclude on my study that buying movie tickets causes rainstorms, right? Because they happened at the same time. Ticket sales went up and it rained. Clearly, the God of Thunder listens to movie ticket sales and said, it's time to rain. No, obviously that's ridiculous. We have to define things. We have to define our independent variables and our dependent variables. So let's re-examine the study and say that weather is the independent variable because we're not able to change the weather, right? It's just the way it is. So now let's say that if it rains, movie ticket sales go up. Can we look at it that way? Would that make more sense? Of course. Of course it would. So when it rains, people want to go see the movies because it's the summertime and they're not going to go to the beach, they're not going to go to the pool. It's kind of gross outside. It's a good time to go inside and watch a movie. That's my hypothesis, right? Maybe I'm wrong. Maybe the really hot sunny days is a good time to go sit in the AC and watch a movie too. So maybe in the real world, the study won't work out that way, but in my hypothetical, it does. So that's one of the ways that you can try to determine if there's causation. You can take your independent variable and see what happens to the dependent variable, which is the movie sales. If you look at things the other way, it's really just correlation. So movie ticket sales and rainstorms go together. They're correlated, but I can't say they cause each other. They just track the same way. So that's probably not the greatest example. I'm sure there's some hole in that example. But the one I often use and the one I've probably read about somewhere online is the tried and true one about ice cream sales and shark attacks. I like this one because you can picture it in your head. So you have two dependent variables. You have ice cream sales, which are basically just happening, and you have shark attacks, which are basically just happening. People are swimming in the water and they're getting eaten by sharks somewhere. Maybe if they're on the coast of Australia or something like that, and they're swimming with the great whites. So you have two variables, right, that seemingly have nothing to do with each other, and for some reason they kind of track together, right? So during the summertime, ice cream sales increase and shark attacks increase as well. So by buying ice cream, are you putting yourself at risk for a shark attack? Or if more people buy ice cream, do more sharks attack people? Or are they related in any way? Of course not. It's the weather that's doing it, right? It's the cause. The cause is the warmer weather. So people are going to the beach, they're eating ice cream. People are eating ice cream in the city, whatever it is. The sales of ice cream are going up, and also people are going to the beach and swimming with the sharks, and that's when people get shark attacks, because they don't get shark attacks in the dead of winter when it's 30 degrees out, unless they're scuba diving or something. So that's like the causation versus correlation problem that comes up with studies. So if we wanted to do this shark attack thing, we would, if we wanted to like really define a controlled study and do this the right way, we'd have to basically take people and serve them ice cream. We'd have to like take 1,000 people from the town where there's a place they can swim as well, and we'd have to serve them ice cream, either 1 scoop, 2 scoops, or 3 scoops. We'd have to put them in different groups of people and kind of figure out how much ice cream we're going to feed them. I would want to be in the 3 scoop category, by the way, because I like ice cream. But basically, you'd look at them with respect to shark attacks. You'd look at people who ate 1 scoop of ice cream, 2 scoops of ice cream, 3 scoops of ice cream, and you kind of follow them and see who got attacked by a shark. And, pretending that shark attacks are more common, and you actually get some events here, then you can kind of say, okay, look, when people eat 3 scoops of ice cream, the shark attacks go up. And then you can say that's probably, it's probably related in some way versus 1. That's a controlled study. You did some intervention. You fed them ice cream as part of the study. And you're comparing this to like a matched group of people of the same amount of people who are matched for age and how much they swim and blah, blah, blah. And they're not allowed to have ice cream. So those matched people are not eating ice cream, and you kind of compare the different groups of, no ice cream, 1 scoop, 2 scoops, 3 scoops, and you kind of see what happens with the shark attacks and see if they correlate. And at least you can say there's maybe it's in some way causative. If you wanted to do a real study, you would do a placebo-controlled study. So you do the same study as above, but instead of not giving people ice cream, you would give them some placebo ice cream. I don't know what you would do there. It's hard to imagine. Maybe some froyo or something. But you give them something that wasn't ice cream that kind of, they didn't know it, though. They thought they were eating ice cream. And then you would have them go about their daily business and see what happens. How many people got attacked by sharks? And then you can say if it's actually correlated. This is silly, right? At some point, these analogies don't make any sense. So it's hard to do with ice cream. But with pills, you can do this, right? You give someone a sugar pill, that's a placebo, or some inert capsule of something. So they don't know what they're getting. The researchers don't know what they're getting. It's called a double-blinded study. Take a group of people and you follow them prospectively, meaning you follow them from day 0 on, and you give half the group who are matched people, you give half of them some placebo, and you give the other half whatever test drug you're doing. And you follow them going forward in time, and you look for these predetermined events. You're not just looking to see what happens. You're defining the outcomes. You're saying that, we're looking for dementia, for example. So we're going to give some people a medicine, and we're going to give some people a placebo, and we're going to follow them every 6 months to a year and kind of look for dementia. And it's already predefined what we're going to call dementia. We're going to do some type of test on them, and we're going to, if they meet the endpoints, then the study shows a relationship, and if they don't, then it doesn't. That's how you do a real study. And that's a prospective study. That's probably it's definitely the better way to do a study, and that can show some causation. If you manipulate one variable and something happens, that shows a possible causation. So that's the best level of evidence that we have in science. What we call a retrospective study is when we follow things that already happened in the past. So, for example, let's look at something from a government database. So if we want to do shark attacks again, we'll say that let's look at ice cream sales in the town that's reported, through the IRS or whatever, and say, look, we sold $1 million worth of ice cream in this town, and we look at a government database of shark attacks in that town during the same time period, and we can make a correlation there. We could look at it for 10 different seasons to get enough numbers, and we can make some type of study there. But that's retrospective. We're not doing anything there. We're not changing anything. We're not influencing the study by changing the variable at all. We're just basically showing a correlation. And this can easily just be explained by the weather and not because people ate more or less ice cream. So these retrospective studies, they can show correlation, but they can't really show causation. We can't prove that one thing really controls the other. We didn't control the variable. We didn't give a placebo, and we didn't really match. How could you really match the groups closely if you're just looking at some type of database? It can't be done. So imagine doing this for drugs. So instead of a double-blinded, placebo-controlled, randomized clinical trial, which is like the best evidence that we have in medicine, where you give people a placebo, you give them a drug, and you follow them going forward for some time period based on some outcome that you're looking for. Instead, do this by looking at hospital databases, look at insurance claims, look at all this stuff that's already been collected. They do this in these big healthcare systems. Like they'll have 1 million patient records, and they'll basically I think it's called data mining. You're basically going into the data, you're looking for correlations, and you're just kind of trying to see if there's associations, and then trying to like retroactively look at the data and trying to determine anything from it. And there's some information to be gained there. It's not like there were terrible studies. I mean, sometimes you can only study some things retrospectively, but in terms of the quality of the data, it's not really the best quality. You're losing lots of information. There is no real control group that's matched perfectly because you're just looking, it's whatever variables they kind of they have in the database is all you have. You can't look back and say, hey, we really want to know about how much they smoke, or whatever, if they didn't record that originally, or if they only recorded yes or no and not how many cigarettes a day. Like you can't get that information back. So there's lots of issues with these retrospective studies. You're kind of at the mercy of whatever was recorded. And especially when it comes to like coding, medical coding and charting, we don't do the greatest job at that. We do kind of a crappy job with coding and charting. And I don't mean like me, I mean like in general in the field, because there's a million different codes. They change all the time. One code works, a different code might work just as well. People have different styles of doing things depending how you're trained, whatever it is. So it's by no means a universal way that we all code and chart things. And now you're trying to use that in a standardized fashion, it just kind of falls apart. I mean, there's definitely some codes that you put in the chart if you need, some drug approved, and there's two different codes that might be reasonable for this person's condition, you use the one that's going to get the drug approved. I mean, that's just the way that medical charting works. It's the way that everything works. So it's like you can't go back and now say that, oh, look, this code was in there, therefore this guy has that disease and whatever. It's not the way it works. So there's levels of evidence to scientific data. The best level of evidence, like I alluded to earlier, is really a high-quality randomized controlled trial, which is where you have placebos and you follow these groups prospectively. The second best thing is a systematic review of high-quality trials. So you take a bunch of different high-quality trials and you kind of review them all using the same grading system and try to determine what's going on when you have bigger volumes of patients going through these trials. And then, looking at the next level of evidence is like lower quality randomized trials. Maybe they're not perfect. There's methodological flaws, but they're still pretty decent. Then you look at these prospective cohort studies, which is kind of what we talked about above. And then retrospective cohort studies, which is what we talked about by looking at databases and whatnot. This is what we're going to look at a lot for the PPI literature, because a lot of it is retrospective cohort studies. So you're looking at stuff that's already been done, it's already out there in the data, and you're trying to like extract information from it. And they're just not the greatest quality studies. Then in terms of scientific evidence, systematic reviews of lower quality studies, and then case control studies, and then case series, like, hey, I got 3 patients with the same thing, let's report it. It's kind of interesting. You read about it. That's how like ideas get into the literature, but it's not really like evidence. It's just like a bunch of different anecdotes. And then expert opinion is actually the lowest quality evidence because it's not really evidence. Expert opinion is great. We use it all the time to kind of like pull together guidelines, but it's not evidence itself. It's just kind of drawing from evidence. It's like if you ask ChatGPT to give you, the summary of these 50 papers, it's going to give you some type of like generalized opinion, but it's not really like its own evidence. So why is it so important? And I'm really getting away from what we started talking about here, but this is the issue. You have to understand all of it. You can't just like look at a couple of studies and make a conclusion if you don't understand how science is kind of working. It's important because science is not really a belief system. It's really a method of trying to discern the truth of what's out there, the ultimate truth, like the universal truth. And we can never actually determine that because there's always a problem with measuring things in the real world, and there's always a margin of error, and our models are never perfect. But science is really trying to get closer and closer to the actual absolute truth of whatever the situation is. The premise is really that like I have an idea and let's try to prove myself wrong. That's really the heart of the scientific method, and it's really it's a method. It's you're thinking of something, you're testing it, you're refining the model, you're repeating it, you're retesting it, you're getting a little closer every time. And then when you get really close, other people start to look at what you're doing and they try to reproduce your data. They run the same type of study, maybe in a different way, and they do it somewhere in a different country. And they try to say, like, this guy is clearly lying to me, so I'm going to do it my own way with my own patients in my own community and see if I get the same results. And when you do that and you find similar results all around the world, then, hey, maybe we're onto something and maybe this is actually true. So science is somewhat self-correcting. You're always trying to prove something wrong. And if you can't, then you kind of move forward. It's pretty interesting in how it should kind of police itself. And if some research center in the United States is making up data, then people in other parts of the country are going to do the same type of study, and they're not going to find that information, and they're going to go to a conference and they're going to say, hey, we found this, how come you found that? And they're going to pick apart each other's studies. So it's kind of like a self-correcting, self-policing field, which is pretty cool. Rarely do we get clear conclusions. We get closer every time, but we never really get like the answer, because every time we ask a question and get some type of answer, we realize there's like 10 more questions to ask. And knowledge and ideas, they are supposed to evolve. And science adapts to this evolution by generating new models, new knowledge, new hypotheses. And it's really a beautiful thing if you think about it. So when people go back and say, oh, look, that scientist was wrong, or look, this is wrong, this paper contradicts this other paper, that's like part of the process. We don't know the answers. We're trying to get the answers. And science is the tool that you use to get the answers. It's not science doesn't know anything. It's philosophically, we can never really know anything. We have to just get closer and closer within our statistical limits, and you try to observe things and report them. Now, this is the opposite of what's called pseudoscience, and pseudoscience is really a problem nowadays. It's always been a problem, but now with the internet, it's a real problem. And it affects everything. It affects the way we practice medicine. It affects people's personal beliefs on things. It affects bad outcomes that people have all the time. And the reason why pseudoscience is different than actual science is because pseudoscience starts off with the conclusion already. So someone who practices pseudoscience will say, hey, these crystals, I know they're good for my inner gut, microbiome and well-being and whatever. And that's the conclusion. They start with the conclusion, and then they start to figure out why that's the case. If they want to go any further and not just go based on just whatever their beliefs are, then they try to look for data. So it starts with a conclusion. It's based on beliefs and feelings, anecdotes, what you heard from somebody, what you saw on the internet, ancient wisdom, the fallacy of natural stuff being better than anything else, etc. And there's a million different things that fall into the pseudoscience category. And then you cherry pick some data from here and there. Maybe you look at a small study that was done in 1982 by some doctor that was debunked, or you look at some study that was done on cells and culture, or you look at some mouse information and you try to extrapolate it to treating a person. All these things are like just ridiculous, but that's what pseudoscience does. It doesn't need to have this like level of evidence like real science does. And people who practice and love pseudoscience, they like to call themselves open-minded. And what's really happening there is just laziness and ignorance, because they just don't know what they don't know. It's dangerous when you know what you don't know, like when you've been trained and seen lots of stuff, and you know that, hey, like this is really uncharted territory. I know that there's more out there. I just don't know what it is. At least you know to stop and pause and look for more information. But when you know it all and you have the conclusion already, and you know the answer is X, Y, and Z that you love, that everything kind of falls. Parasites are one of these things. You have all these GI doctors. They're not really doctors. They're like naturopaths, or just people off the street that call themselves whatever they want to, because there's no real criteria to be a quack. Basically, these people call themselves open-minded, and they say that, we know the answer. It's the parasites. Everything's the parasites, or everything's SIBO. Have you had your microbiome checked? And they're not really open-minded at all. They're completely closed-minded. They're just looking at they're looking at the problem through their lens of whatever their pet theory is, and they don't know what they don't know. They just don't. They're oblivious to what they don't know, which is what makes them dangerous. So this kind of surety and that they know the answer, they have the answer, that's like a red flag that you're dealing with a pseudoscience practitioner. So you should run from that. But it's really important to make these distinctions, because right now in the current climate in the United States, we're facing basically an all-out assault on science, research, higher education, and just the very idea of intellectualism. And this is going to have negative effects on our society and the world for decades to come. We have decided, and I put that in quotes, as a country, that being smart is now a bad thing, and that anyone's feelings and harebrained, stupid thoughts that they have deserve as much consideration as decades of scientific research and consensus from an international community of some really smart people that are out there. And we have an administration that is anti-science and anti-intellectual and is bent on destroying the United States' standing as the world leader in scientific thought and innovation. So the analogy people use for this is that we're shooting ourselves in the foot, but it doesn't really capture the gravity of the whole problem. Because if you shoot yourself in the foot, you can still hobble around and eventually you'll probably get better. Maybe you'll be in the hospital for a couple of days, have a minor surgery, but you get back on your feet. What's happening right now is more akin to shooting oneself in the head. We're censoring studies, we're budgeting funds to study quackery and pseudoscience, we're cutting spending on public health and disease prevention, and we're doing it in the name of, quote, efficiency. The end result of this will take decades to fully realize. But what's going to happen is going to be a massive drain of brain power from this country. And many other countries are elated to receive some of our best and brightest minds from the United States. And they're welcoming people into their labs and their universities and their industries. So it's important to understand a little bit about science and the scientific method, to understand how we draw conclusions and get to the data that makes its way down to patient-level recommendations. So when a patient goes to see a doctor, I can't just say, take apple cider vinegar because some guy at work swears by it, or I saw it on Reddit, or whatever. I can't say that because I have to have evidence, and not all evidence is created equally. Now, I digressed a little bit there, maybe. But I should get back to PPIs and dementia. So how could we study PPIs and dementia to see if they really cause dementia or not? So if I was going to design a study, I would take about, 2,000 people, whatever the number is. You need to do an analysis and figure out the power of the study, etc. But I would say, let's take 2,000 people and we'll match them on factors that cause dementia. So we'll make sure that they're similar in terms of age, sex, body mass index, socioeconomic status, family history of dementia. They're eating a similar diet. They don't drink, or they drink the same amount of alcohol. They don't smoke, or they smoke whatever the same amount is. They have the similar medical problems, diabetes, high blood pressure, neurologic issues, etc. And we'll basically divide that group in half, and we'll give half the people a placebo, and we'll give the rest 40 milligrams a day of omeprazole, or whatever the study drug is going to be, the PPI. And we're going to follow them for 20 years. And we're going to check in with them every year or so. We'll have a neurologist do like a mini mental state exam, and we'll look at their medicine compliance, and we'll look for anything else that came up in the year of the study. We'll make sure they're taking the placebo, make sure they're taking the other medicine, look for side effects, kind of do the whole thing. And every couple of years, we'll do an interim analysis, and we'll see what's happening, and we'll follow the study out for 20 years, or maybe we'll do an extension. We'll follow it out for 30 years until I'm 80 years old, and then I can finally publish that study. And that will be a definitive proof as to what PPIs do with dementia. So what's the problem? Well, the problem is we don't have studies like this because no one's doing a 20 or 30-year study on a drug with an outcome like dementia. It's just not happening. It would be very prohibitive for someone's career to do a study like this. People only live so long, so you can't have, you'd have to design this study now and then send it out for the next 20 or 30 years. We just don't have prospective placebo-controlled trials for PPIs with dementia that last for more than just a couple of years. And dementia can take many, many, many years to occur. So we don't have that high level of evidence. But what do we have? Well, next time on part 2 of this long episode, I'm going to discuss the studies that we do have. And we're going to try to draw some conclusions about PPIs and talk about the risk of dementia and talk about how I counsel my patients on what to do with their PPIs with respect to dementia and really these other risks that have been brought up in the past. So make sure that you stick around for part 2 of the PPI and dementia episode. And thank you for listening. I know I digressed a lot on this episode, but I think a lot of this stuff is important to understand how one thing affects the other, and it's not always apparent by the way it's thought of. And some of these things, it's really a domino effect. So it's very hard to take science out of the equation and think that things are going to turn out bright and cheery 20 years from now. I hope you enjoyed listening to this episode of The Real GI Doc Show. Please subscribe to the show on Apple Podcasts or your favorite podcast player to catch my next episode. If you really want to show your appreciation for the show, take a moment to rate and review the show on Apple Podcasts. It only takes a few seconds and is the best way to get other people to discover the show. If you use social media, you can find me under the handle @RealGIDoc, so feel free to follow, leave a comment, or just say hi. If you have a question about something gastro-related that you'd like me to answer on an upcoming episode, go to realgidoc.com or use the link in the show notes to leave me an audio question.
That's it for this episode of The Real GI Doc Show. Make sure to join Dr. Gandolfo next time to explore another interesting topic in gastrointestinal health. And remember, the views and opinions presented in today's episode are for informational and entertainment purposes only. Nothing discussed in this episode should be considered or used as a substitute for medical advice, diagnosis, or treatment. If you're experiencing a health issue, please consult with a doctor or a medical provider in your area. Thanks again for listening to the show.